Dr. Robert Bates from the Concussion Center of Fitchburg, and today we are going to continue with part two of the concussion series, where where we will talk about examination. Now, in examination for concussion, it is a very thorough examination, and we check hundreds of things. But you will see as we go through this that we may go in different directions depending on what type of subtype or what things we are seeing in evaluation. So, first of all, previous to the physical examination, we can look at various imaging. Now, some imaging gives us insight into concussion today, diffuse tensor imaging and PET scan and functional MRI, but these are not done very often and cannot be done in many facilities. So usually someone comes from the ER, they've had a CAT scan to rule out a fracture or a major bleed. Not that helpful in mild traumatic brain injury or concussion usually. We also can look at blood work. There are new tests done to look at breakdown of cell product and other things that can suggest there is some brain damage, but neither the imaging or the blood work gives us any specificity into what parts of the brain may or may not work. So we move into a very complex examination. We first usually look at gait speed. And we can tell an awful lot by gait and gait speed and the amount of arm swing and symmetry of gait, stride length, whether the patient is in good balance. We also dual task them where we have them do other things, and it will bring out pathology a little bit more when we do that. We do all of the standard range of motion, deep tendon reflexes, sensations, and strengths. And we move into an eye evaluation where we look at the movement of the eye in various what we call saccade, point A to B, and also in visual pursuit. And we see if the movement of the eyes are accurate. Very often in concussion, the eyes have a problem about 95% of the time from what the research shows. So we'll see a hyper or a hypometric movement, a saccade that's not right in movement length. We'll see increased latency, usually frontal lobe. We will see the cerebellar abnormality of dysmetria, as I previously talked about. And we may see a slowing speed, which can be midbrain for burst neurons and other activities. We look in the eye to look for other pathology, look at the veins and arteries, and it's a nice place to be able to look and see a very small nystagmus or movement of the eye that shouldn't be there, which we will evaluate with other mechanisms as well. We move into actually, I have designed my own examination sheet because there are so many things to check, and I'm just going to zip through some of these. We look at visual appearance, we look at the mental status, and of course we might have already done some testing that I'm going to run through to try to subdivide or bring the patient into a better diagnostic criteria of one of the subtypes before we actually do the examination. We also look at step testing, Fukuda testing. We look at subjective visual verticals to see if the patient perceives vertical in the right dimension, or is it more of an eye problem, or is it more of a central problem, and that requires further testing. We look at Romberg, modified Romberg, whether they have lateral pulsion or not. We look to see if their head is tipped one way or the other. We check glabella signs, startle response, whether the person has any of the UPDRS scale abnormalities for Parkinson's disease. We look at their facial musculature and their various cranial nerve activity. Face sensation, corneal reflexes, whether the pupils are the same size, whether they have an abnormality of the triad of convergence, Their light response is direct and indirect. We look at cover-uncover tests to see if they have any evidence of aphoria or atropia, the eyes not lining up properly with each other. And we move into various things like OPK, optokinetic reflex, see if that is normal. There are many types of saccade and visual pursuit, and we try to get a feeling for which ones may or may not be normal, giving us information about more specificity in the brain where there might be a problem. We look at various head-eye movement activities to see if the vestibular ocular reflexes are normal with head impulse and head rotation, visual acuity, post-rotational nystagmus. We may do very specific testing with a rotary chair and goggles to see if the patient has normal rotatory nystagmus and post-rotatory nystagmus. We also might do balance testing, computerized balance testing, to evaluate the differences between ocular, vestibular, and somatosensory input for their balance mechanisms. And I use a right eye system, which is a visual eye tracking system. I've been using it for about 3 years. Excuse me. And this gives us a lot of information about the accuracy and speed of saccade, visual pursuit, and many other things. It's really state-of-the-art activity. We look at vibration in different parts of the body. We look at their pass pointing and extinction activities, accuracy of arm to or finger to finger, finger to nose, finger to movement. We listen to the heart and listen for murmurs and so forth. We also check the blood pressure in 3 different positions to see if they have evidence of dysautonomia, which I'm going to talk about in a few minutes. We look for visible fasciculations. We do a very thorough cervical evaluation. We may or may not have taken cervical x-rays depending on what we see in history. But we do joint position sense testing, error testing. We do smooth pursuit neck torsion testing, head-neck differentiation testing, cervical flexion rotation testing, and also deep cervical flexion endurance testing. It is very important, as we will see in the next part of this concussion series, to differentiate between the sensory input of vestibular, ocular, and somatosensory. So we need to do tests to see how much of each is involved creating the symptoms for the patient. So we may do many types of testing that the patient can do. Some of the new testing on the iPhone or on a smartphone. I presently am using Brain EQ, which tests 8 or 9 different things. The patient can do it on their own. It's very accurate. It's very hot in the literature right now. Many concussion clinics are using it. And it gives us a lot of good information. Not only that, but the patient can do it on their own, and we can also look for outcome assessment. What's getting better, what isn't, if they have a flare-up. I also use Cambridge Brain Science. I use C3 Logics from the Cleveland Clinic. There are many different types of written tests the patient may take. Now, they're never going to take all of these. That's why a thorough history is important before we see the patient, because I'm going to read through a list of the things that I use intermittently in my office, and you will see there are many of them. Sometimes they're necessary, sometimes they are not. I use the HIT headache impact test. I use the River-Mead post-concussion symptoms questionnaire, the acute concussion evaluation, the child SCAT-3, the Long-Baker Faces Foundation Faces Scale to see, especially for children. I use the Epworth Sleepiness Scale. I use the Fatigue Severity Scale. I use the Migraine Disability Assessment Test. I use the Post-Traumatic Stress Disorder Checklist, the civilian version. I use the MOCA test, which is most sensitive cognitive screening tool. I also use the pain disability questionnaire. Now for balance, which is very often a problem for patients, I use the specific balance confidence scale. I use the dizziness handicap inventory, the DHI. I use the balance error scoring system, the BESS. I use the falls efficacy scale, the risk fall assessment tool by Johns Hopkins, the fear of falling avoidance behavior questionnaire, the lower extremity functional scale. We also use the Berg balance test and rating scale, the best balance evaluation, the Fullerton advanced balance scale, and the functional gait assessment. We very often, and are going to use it more and more, use the core Q, which stands for the Consolidated Criteria for Reporting Qualitative Research. It gives us information for sensory tolerance, physical activity tolerance, mental activities, life activities, and social participation. If we have thought that the patient by history and through some examination has dysautonomia, which is very often not diagnosed and actually quite common, and in the literature is responsible for a lot of the chronic problems with patients, there are several things that we do. There's a new app, a pupillary reflex app, which gives us 8 criteria. 4 of them are very reliable for dysautonomia, especially the 75% time to return to dilation after constriction light response. We use the heart rate variability because people don't realize, but the heart rate is constantly varying in between beats, and that is a normal autonomic response in your body. We use the blood pressure in different positions, which should follow a certain normality. There are several tests, both hot and cold, hand-foot stimulation, and mathematics calculation stressors, which should create a sympathetic response and some change in pulse and blood pressure. The one that we use mostly is the dynamometer grip strength, where we have the patient give a maximum grip strength, and then we use a third of that for 5 minutes, and we should see a certain amount of change in the pulse and the diagnostic blood pressure, or diastolic and systolic blood pressure. This tells us that the autonomic system is working normally and actually changing in response to things it needs to do. So you can see that it is a very, very complicated evaluation procedure, which is different for every patient depending on what the history and the initial part of the evaluation has shown. So in the third part, we're going to cover a lot of the treatments, and again, we will talk about CTE. But I am signing off for today. Stay safe and be happy.